All right, folks, I think we're at quorum, so we can go ahead and get started.
You're confusing me. You're usually not.
Well, that's what I said. I'm going to keep people on their toes.
We have a lot to get through today and a vote ahead of us this afternoon. So my goal is to keep us on track and on target. I would like to start by calling the August meeting of the Rhode Island Opioid Settlement Committee to order. And we will start as we always do with introductions from the committee and then the state staff who are staffing the meeting today. So why don't we start with Sean to my right and we'll go around the horn.
Good afternoon, everyone. Sean Lacey, Town Manager, Westerly.
Good afternoon, Rich LeClaire, BHDDH.
Good afternoon, Dee Goldstein for the Attorney General's Office.
And I'm Julie Hamill. I'm the State Court Administrator on behalf of the Chief Justice.
Good afternoon. My name is Miko Lincoln. I'm Community Representative.
Rachel Ferrara, City of Providence, Mayor's Designee. Alex McAdoo, Brown University.
Clark Donnelly, Newport County.
Maria Santos, Franklin, Providence County Representative.
Jeffrey Brown, Kent County Representative.
Katie Hansen, Director of Adult Outpatient at Thrive Behavioral Health.
Thank you. And we'll go to the state. Brent, I'll introduce you in a moment. Kathy.
Kathy Schultz, Director of the Governor's Overdose Task Force.
Anna Nubai, OHHS. Still not associated Interagency Resource.
And Michelle.
Hi, Michelle Goncalo, the Finance Manager for Opioid Funding at OHHS.
Stina Schultz, Lead Analyst for the Overdose Task Force.
And my name is Brandon Marshall. I'm a professor of epidemiology at Brown University and also have the pleasure of serving as chair of the settlement committee. We have a few more members joining us. I think there's some space there, Director Larkin. Senator, would you like to introduce yourself?
Sure. Jake Bazillion, Senator for Senate District 1, which is right here. Welcome.
Thank you. Happy to be here. And Director Larkin, whenever you're ready.
Ready now.
Jerry Larkin, Department of Health.
Great, I don't know who I am.
Thank you all, appreciate it. So our first order of business is approving the minutes from the last month's meeting. They're in front of you here. Can I get a motion to approve the minutes?
Motion. So moved.
Any second? All in favor? Second? All in favor?
Aye.
Any abstentions or nays? Great, those minutes are approved. Okay, so we're going to go right into our agenda. Can you move to slide 3, please, Bill? We have a lot to get through. We heard a lot from you at the last meeting in July, and we've done our best to be responsive. We have a lot of information for you in response to those queries and recommendations to come back to you with more information. So we have a lot to get through. We're going to start with a presentation from the URI team on the status of the evaluation, and then also hear from Chris, who will go through some of the statewide indicators to measure our progress in addressing the state's overdose crisis. And then we have some more updates for you on the current status of the budget to date and programmatic updates as well from Kathy and Michelle. And then we're going to get to the meat of the meeting today, which is walking through the recommendations that we introduced last meeting. We're going to walk you through a little bit more around the rationale for those recommendations and what led us to the recommendations that we have for you. We'll then spend a good deal of time discussing those recommendations and conclude with a vote today, in addition to 2 public comment periods as we usually do. Okay. So I will now turn it over to Brian Blissmer, who is a professor at the University of Rhode Island, just to give us an update on the intervention evaluation program. Whenever you're ready, Brian.
Thank you, Brandon, and thank you everybody for having me back here. I just want to take a second, Brandon already did, reintroduce myself. My name is Brian Blissmer. I'm a professor at the University of Rhode Island. We have a core team for the evaluation with Dr. Lynn Stein and Megan McCormick. And we've added, and I'll talk about them in a little bit, Dr. Andrea Paiva and Jolie Tynes to do some work for us based on their expertise. Unfortunately, this is a super busy week at the university as everybody shows up next week and faculty start contracts. So they are not able to join today, but you did get me out of one meeting. So that's probably Next slide. So I wanted to start today with some slides that actually were already presented to this group. So I apologize for that, but I think it's important to kind of reset where we're at. So just really to remind you of our goals and approaches here. So I'm not going to spend a lot of time on them. We're not going to read them all in depth. We've done that before. But this first slide represents the primary task that were agreed upon with EOHHS. I'm going to discuss a bunch of the activities in more depth later that we're engaged in here, but I want to highlight here on this first thing, really there's only one bullet, and that's number 2 under task 2, that's program-specific evaluation. So a lot of the things are at a higher order and a higher level, and that's some of what we'll talk about, the activities that have been going on today. So in keeping with the nature of the agreed upon task, we're doing this work in partnership with UHHS, its associated agencies. We've established an overarching framework for evaluation. We're actively working with UHHS and the work groups to refine recommendations and discuss gaps in data sources. I'm going to give some more information on that again in a minute. We do have the ability and funding flexibility to expand our team as needed. So as mentioned at the outset, we've already pulled in a couple of new team members to assist. So Dr. Paiva has evaluation experience, has worked on the risks, but also has hands-on experience working in regional prevention coalitions. So she's helping out with some of the prevention side work. Julie Tynes has expertise examining programmatic outcomes. She was pulled in to handle a specific EOHHS request that we'll talk about in a second. And I just want to reiterate here kind of the last point on this slide. I know they're a little small to read, so I apologize. But this remains central to what we're doing here. This is a true partnership in the truest sense of the word. So we are relying upon data being made available to us from agencies, from funded organizations, population health metrics. We're not funded at a level to collect new program level data across the big breadth of activities that are funded here in the state for opioid and overdose response efforts. So just again, kind of to make that point, we're a partnership. We are relying upon data being provided to us to do what we want to do. So I want to spend, next slide, a bulk of the time here talking about activities. So this is just a general set, and then we'll get into some more specifics here. So we have now finalized the overarching framework. It's based upon the CDC guidance as outlined in primary task 1. It's an integration of the cascade of care and collective impacts model, something we talked about generally last time I presented. We drafted the overall logic model in accordance with that overarching framework. And the process that we're engaged in now is going pillar by pillar to examine that logic model and implement the evaluation framework as laid out in task number 2. So what that means is we're doing in-depth literature reviews of the scientific evidence in the area. We're reviewing pillar-level programmatic inputs and outcomes to create driver diagrams and logic models within each specific pillar. And then we're working to look at the alignment of those programs and the logic models with the overdose task force pillar strategies and the current metrics that are being used to evaluate those strategies. So really trying to look at what are best practices that are out there, what's the alignment with what's happening here in the state. And we use that to then develop a set of recommendations. And I'm going to walk you through some of this process specifically for the prevention pillar here in a couple of slides. We're doing the same kind of activities with the other 3 pillars under the leadership of different members of that core evaluation team. I was responsible for the prevention pillar, that's why I'm here today, but other people are working on the other pillars. Just as part of task number 3, just as an example, Megan McCormick has been working with the RIDO Overdose Fatality Review Coordinator and epidemiologist, as well as with the EOHHS evaluator, who was Tamara Berman, to develop progress indicators for the 5 most frequent recommendations from the OFR team. She's presented to all the work groups and gathered feedback from key stakeholders. Feedback was compiled, reviewed to determine potential indicators for each of the OFR recommendations. So there was an issue where the same recommendations were coming up year after year. What's being done to track these? Are we making progress on them? So she took the lead in working with others to say, here's a potential set of recommendations. So they are being reviewed and refined by appropriate data contacts at state agencies, going to be presented to the Small Data Council, and then go back to the work groups for approval. And then an example of specific program evaluation, Jolie Tynes and I worked with Tamara Berman at EOHHS to develop short evaluative infographic outcome reports for each of the 7 prevention projects funded from the EOHHS opioid settlement funds that were distributed from the Rhode Island Foundation. So the documents are all drafted. They're being reviewed by the funded partners now prior to being finalized. And these are meant to be useful for the programs, but also to be useful for looking at the next round of funding. So what have they done? What have they accomplished as they look towards the next round of funding for them? Next slide. So this really kind of highlights the process that we engage in, and I'll talk specifically about the prevention pillar, but this is the same process created for all the pillars. The initial step is for us to complete the literature review and develop the associated logic model and driver diagram for the area. We share this then with the EOHHS evaluation team for review and revision. As part of that work, we identify and create a set of recommendations for moving forward with the evaluation plan. Following that refinement, we share that out with primary stakeholders. So in the case of prevention, we share that initial work with members at BHDDH and the prevention work group. After we get their comments and feedback, it was taken to the smaller internal overdose data council or ODC, and then to the full or large ODC for their input and guidance. Next steps, which is where we're at with this one, involves finalizing the recommendations and metrics, and then working with the agencies to identify potential data sources. So that's where we're at with prevention. Slide. So these are really busy slides, and it's almost purposeful, right? I don't want you to read all these slides. You can visually see what I'm going to try to get across here. So as you can see, on the far left, this is our core strategies. This is the first core strategy in prevention. We've got identified programs, what the programs are if you want to learn about them, what data is being tracked, and who it's coming from. With the first strategy, you can see there are quite a few programs that have been identified. There's some metrics there, so number of student assistant counselors in the schools, all the kinds of metrics that we use for the reports that Jolie did for the Rhode Island Foundation projects. So you can kind of see that piece there. Next slide. Then we move on to the other strategies, and I think it's pretty clear from a visual perspective that we've got a lot more holes here. So as we look at these strategies, there's not necessarily specifically identified programs, therefore there's no specific metric for a lot of these. There are some, so for some of the prescribing pieces, there are tracking data that's available there as an outcome level, but there's no process level. So what we're trying to do is look at what's out there, what do we say we want to do as a state, how does that line up with the best evidence that we have, what's actually being collected and measured and funded, so that we can look at overall impact of these programs. Next slide. So again, a real quick examination of those slides comes with two major takeaways. The first is that there's several strategies where there's limited programmatic activity. Is that by design? Is that a good thing? Is that a bad thing? That's not necessarily for us to decide. It's just this is where we're at currently based upon the information that we have. And then where there are indicators, they're sometimes only at the process level or only at the impact or outcome level. There's not really a nice blend of process and impact metrics for these different programs. So we're currently working with ODC and the various data holders and agencies to identify how do we best capture insightful indicators at the strategy level. With respect to the current pillar strategies, so that list that's on the far left, we have created some recommendations, which I'll share really quickly in the next slide. But it's important to acknowledge there's a potential to re-examine these identified strategies as part of the upcoming strategic refresh, which is being led by Kathy Schultz. That could lead to consolidation, new or different strategies, differential funding priorities, et cetera. So this we view as an important part and piece of information for these groups to try to make these decisions as they move forward. Next slide. So the comprehensive core or comprehensive prevention core strategies, the current strategies are listed on the left. Based upon our review of existing programs, the scientific evidence for best practice in prevention, we created a list of potential things to explore as recommended strategies. Each of these were presented along with supporting scientific evidence to the work group for their consideration ahead of a strategic refresh as a potential resource to enhance their work. And next slide. And really, as I close and prepare to hand this off to Dr. Chris Schultz, the EOHHS Overdose Data Analytics Lead, I want to reiterate and highlight that our involvement, just to be clear, is relatively short term, okay? Relative to how long the settlement funds are going to be in existence and how long Rhode Island wants to address the overdose and opioid issues in the state, we're a short-term investment piece. So in collaboration with EOHHS, we feel that providing guidance in developing a robust, updated data system that aligns the metrics by pillar and strategy will provide the greatest long-term impact. So in talking with the agencies, I've learned that there's a lot of data that's not necessarily being presented out at an easily accessible level. And that's some of the things that are takeaways for me. The data exists for the large part for what we want to look at for metrics. It's figuring out how do we get that data? How do we pull it into a system that now aligns with the different strategies that we have in place? And how can those be updated regularly? In the long term, we think having a dynamic system that allows you all and or others to use dashboards that have both process and impact or outcome metrics is ultimately what's going to be useful for a lot of different use case scenarios. So having the ability to look at how are things going, how are they being implemented, what's happening out there, and look at associated outcomes with those things is ultimately what's going to be useful for driving decision-making going forward. So that's kind of where we're at. I really now, I'm just going to hand it over to Dr. Schultz to talk about an update on the overdose data council.
Sure, yeah, Chris. Yeah, and then we'll take questions after Chris's presentation. Let me.
And you can, so you can stay on stage. Thank you. Good afternoon, everybody. I'm Christina Schultz. I also go by Chris. No relation to Kathy. So I just want to level set us before I go over the metrics that the Overdose Data Council has settled on, although they may be updated after the strategic refresh that Kathy will be doing. Just a couple questions that I noticed have come up over the last few OSAC meetings. I just want to address them before we go into the actual metrics because they're a little higher up than I think you're expecting. So the first one is, how do we compare program performance with one another, okay? And the second one is, what specific activities are we conducting? Which ones are directly leading to decreases in overdose fatalities? What's working? It's not that easy. I just want to clarify with everyone so we're all level set. So for the first one, we can't compare program performance with one another because programs are delivering services to individuals at different points of the continuum, right? So for example, if we have a program that's delivering harm reduction supplies, we can't compare that directly to a program that's providing recovery housing. We can't do that, right? Because they're both important pieces of the continuum and providing care. The second one, with identifying specific activities that are driving down the overdose fatalities, correlation is not equal causation. And I see Dr. McAdoo has probably heard that a number of times over her schooling. Basically, we can't say that one has caused the other unless we're performing some experiment, which we are not doing at this point. What we can do is say, okay, there are associations maybe between the number of naloxone kits that we're distributing, number of fatalities that we're seeing, right? But we can't say that this specific thing has contributed, okay? What we do is we take a step back, we consult with subject matter experts, the community, empirical research, and from that point, right, we come up with metrics that really are measuring our performance, and in turn, how is that performance impacting lives? Okay, not yet. So today I'm going to be going over the scorecard that we developed. This scorecard, you're not going to see any data today. However, if you are interested in the data, it is in the semi-annual report on PORI. And then the next one will be, that's for March, and then the next one will be updated at the end of September. So plenty of data to view. I'm happy to answer any questions if you do go on the site and take a look. Okay. Yes. All right, and so we took a similar process with the Overdose Data Council as Brian sort of outlined, with the subject matter experts, research, work groups had a lot of input, community voices. So basically for each of the pillars, we identified metrics that we believe are tracking our performance. So for the first one, for overall strategies, obviously we are tracking the number of accidental drug-related overdoses each year, and we are, knock on wood, we're not complacent, but moving in the right direction there. And then we are also are looking at the number of emergency department visits for opioid-related overdoses. That is something that we've tracked for some time now. And so those are our overall strategies. I will say we are also tracking other metrics, but these are the ones that we've really honed in on to present to the public. Next slide, please. Okay, prevention strategies. Brian just provided a lot of information. There's more where that came from, but we are using URI's evaluation to further our own understanding of metrics that we may not be tracking right now, but we should be seeking out. So for the first one, we have increasing the number of schools with Rhode Island student assistance counselors. These are counselors who have been trained to provide substance use information and provide mental health. The second one is our secondary metric, is sustaining the number of opioid naive patients receiving an opioid prescription. And then we try to implement an equity lens to each of our pillars. That one is increasing the diversity of the Rhode Island student assistance workforce, and then also looking at racial ethnic disparities among students receiving services from the student assistance counselors. If you do see anything that says under review, it's because we are still working with not only accessing the data, but coming through it, making sure that we're on the right page with what we have. All right, next is our harm reduction and rescue strategies. Most of you know we are tracking the number of naloxone kits distributed in the community each year, and we're in good shape there. We're also tracking the number of in-person harm reduction encounters each year, as well as the number of individuals served, hoping to increase those over time. And then again, we're having an equity lens where we're also aiming to reduce disparities in the number of naloxone kits, as well as the number of encounters and individuals served. All right, we have two more, but treatment has 2 slides because. So our primary metric is work in progress right now. We're looking at the rate of people connected to treatment within 6 months of an overdose. And so that's not opioid specific, any substance involved. That's what we're trying to do, is identify if those individuals are connected to care. For our secondary metrics, we have a number. We have the first 2 are sustain the rate of people receiving sustained buprenorphine or methadone treatment. And we're also looking at increasing the cumulative number of individuals who are receiving buprenorphine or methadone. Next. Our final 2 metrics for treatment. The first, it's a secondary metric, but increasing the number of healthcare professionals who are prescribing buprenorphine each year. That's an annual metric that we track. And then the equity lens is it's in line with the primary metric, where we're looking at the rate of people connected to treatment in 6 months and how that's broken down by race and ethnicity. Okay, and then for recovery strategies, our primary metric is increasing the number of certified peer recovery specialists and community health workers. And so we update that a couple times a year. We get the data from the Rhode Island Certification Board. And then the secondary metric is increasing the percentage of individuals leaving a certified recovery house for unstable housing. And then lastly, our equity lens for recovery is increasing the racial and ethnic and linguistic diversity of CPRS and CHWs. And also assessing any potential disparities among individuals in race and ethnicity of individuals who are leaving certified housing, seeing where they're ending up. And that concludes my list of metrics. I know that was a lot. I was working with, I don't even know how much time I was allotted. I just kind of went for it. So if anybody, I'll let you guys transition us, but thank you all. Any questions, please feel free to reach out.
Thank you. Yeah, we have a few minutes for questions, and Kathy's going to get next into how the programs funded by settlement, stewardship, and federal funding align with these metrics. But let's dive into some questions for our presenters, Dennis and then Mako. Yeah.
Just for clarification, first of all, say the scorecard is looking at 2025 or 2024.
That's a good question. So we are updating. So the March report, most of it's up through 24, but next month I was actually working on it today. We'll have more Q1 to Q2 data for 2025. So end of September.
And a follow-up question, just again, just so I understand, the difference between in progress and in review, under review, with the arrow, it's deceptive. So it's going up, oh no.
So, yeah, so for the in progress, that's tracking the data that we already have. Under review is a target that we're trying to set. Some of them are they're a little more difficult to ascertain, even if we can set a target. Or if it's just monitoring. Yeah.
Under review is looking for a.
Oh, the under review, which
Well,
on the slides?
I'm sorry.
No, no. Oh,
I'm trying to determine what number to.
yes,
utilize.
and even if it's possible, some of the data is, yeah.
Thank you.
Mako, did you have a question?
Yes, I apologize. Yes, I do. Thank you, Kathy, very much, Kathy. What I want to say is, I apologize. Regarding the certified peer recovery specialist, you mentioned the Rhode Island Certification Board, and I think a couple of months ago, I went and looked at some of those numbers, and it was like 232 certified peer recovery specialists in the state of Rhode Island, but only like 30 of them were like African American or something. So I know to increase the number, but I think, is there a way we can increase the diversity in that particular workforce as well?
That's a great question. I think that's something we have to have conversations with the certification board on, and other outlets who are more responsible for recruitment and training.
Thank you.
Do you know, does that data exist?
Yes, I'm waiting for
Or is it the cert to your, is that a knowable number? Yes.
Yeah, so if you actually look at the dashboard, I don't have it off the top of my head because there are a lot of metrics, but if you look at the dashboard for March, you'll see the breakdown for race, ethnicity, and linguistic ability.
And it applies to this as well.
The CPRS, and so yes, the data that's in line with that metric
All right.
is online.
Thank you so very much. Yeah, that's what I meant, because I know the certification dual board is a wonderful job right now, recruiting a number of different things. So, thank you.
Yes.
Okay, so under treatment strategies, after you use a time frame of 6 months after an overdose to get, why did we select 6 months? What is
That's
it?
due to empirical literature that 6 months is a very sensitive time period to connect an individual with care. I would imagine.
Nothing to do with bed spaces or anything like that. It's availability of beds for treatment.
That'll influence it, but it also depends on the nature, the person's need, the point as to which the individual is on the continuum, readiness for treatment. There are a lot of things that we need to consider with regard to connection to care. Yes.
Okay, thank you both. Please hang out for the rest of the meeting in case anything comes up. Perfect, appreciate it. Thanks, Brian. All right, we're going to go into our first public comment period before we get into the real nitty-gritty of the budgets and program recommendations for fiscal year 2027. So let's maybe start with the in-person comments. We will have another public comment before the vote. So I just wanted to, again, offer 2 public comment periods so members of the public don't necessarily need to stay right to the end. Any public comment? Yes, go ahead.
Hi, I'm Catherine Diorsi from Integrated Healthcare Solutions. We're one of the program recipients for holistic recovery supports from this group, from the city of Providence, so thank you. I just want to say that Christine questions up front really about not comparing programs, the inability to do that, and then also too, because we're directly working with these individuals, and really what we're really seeing is that, and I know this is your tall task, like how do we fund all these pillars? But it's so desperately needed to fund all these pillars. And so, because we're seeing some of our individuals really struggling when their recovery housing falls apart and they're losing this and they're struggling, we're trying to keep them going. We're seeing the jobs impacting just so many of all the pillars that fall all around. It's really impacting their lives. And so I just want to, you all know this, I know you know this, but I wanted to emphasize we're seeing it real time. And then just secondly, about the CPRS CHW, and this is just an idea, to maybe also include an expansion of that team, to also include certified health coaches. Because like Michelle and I, we're peer recovery specialists, but we are also certified health coaches. So we add in another level of education, access, support, resources that they don't necessarily may or may not get. And so you have an opportunity to actually even expand upon that team and bring some diversity in that way. So just this.
Thank you so much for that comment. Any other comments?
I just have a
go
quick
ahead.
question. I'm Michelle Alborg and I'm with IHS as well. One of the things for the tracking, is there tracking going on for the people that are going to the safe injection site? And are they getting help to maybe seek recovery? Like, how is that working? And is that being tracked?
We are currently we just have the data shared with us, so we're currently combing through it right now, but we do have the ability to identify those who are receiving treatment or, receiving services. But Kathy, in terms of like tracking, that's not like specific individuals or anything like that. That's not something that we do.
It's disaggregate data. So
Yeah,
we're not getting,
we're not getting aggregate data.
There's no identifying information, but we are, just to clarify, anybody else who would like to speak, it is not just, it's an overdose prevention center, so it has all resources around it, and I welcome anybody else to add to that, but it is not just about that. It has all levels of care across the continuum.
Okay, any questions on Zoom still? Great. Okay, we'll come back to a second public comment before the vote. I wanted to move us now to an update on where we stand in terms of the budget. And then also, you all asked for more information on how the settlement funding fits into the larger picture of the resources the state receives from the federal government and from another pot of money called the Stewardship Fund, which is essentially a tax on opioid prescriptions. So we prepared that information for you to help guide and contextualize how the settlement funds fit into the bigger picture of the state's overdose response. So Michelle's going to walk through the budget numbers, and then Kathy will walk through how the settlement fits in the larger picture of all of the resources going towards addressing the overdose crisis. So go ahead, Michelle. Yeah, can you see the slide?
Next slide, please,
Great.
yes.
Okay.
All right, so hi, Michelle Goncalo again. I'm a finance manager on the budget side. So last time we've heard from all of you that you wanted to see the allocations with the carry forwards. So we prepared this slide. I just please note that all allocations, like from fiscal year to fiscal year, it's carry forward. So here we have presented in the first column, we have FY25 allocations, which is about 18 million. And then the second column, which is our enacted budget, which is basically all of the allocations from fiscal year 23 to 25 plus the unspent. So this is our budget that went through for 34 million. Then the third column, FY25, is the unspent. So this is where the unspent is basically all of the allocations plus spent that's taken place through FY25, but through 8/6. So we don't have all the data yet because we're still closing out fiscal year 26. But this is what we have till now. So we have 23 million for FY25. So then you voted last year for FY26 allocations of 20,700,000. And then the last column would be our total unspent FY25 plus the 26 allocations will bring us to 43 million to start the year, which will be the revised budget. It was the recommended, but it actually will be the revised budget come next month. So that's the last column. I'm gonna hand it back over to Brandon for discussion.
Yeah, we can stop here and answer any questions. I've got a few notes as well, just to clarify. I always get confused, Michelle, with fiscal years. They represent the end date. So we're currently in fiscal year 2026, which ends June 30th, 2026. Today, we're voting on the allocations for fiscal year 27, which is not shown yet, but that would start July 1st, 2026 and go through June 30th, 2027. So I always find that confusing. Just wanted to clarify. And then one other piece that I want you all to keep in mind for the discussion later and for the recommendations we're presenting for you is that the amount that is unspent does vary across the columns, right? And there are some pillars where we see a relatively high proportion of unspent to allocation. So for example, specifically the social determinants of health pillar. Last year, this committee recommended an allocation of 2.1 million, but as we see, there was also more than double that unspent from prior years, which effectively gives that pillar 6.5 million. So we'll come back to this later, but some of this level of unspent is driving some of the recommendations that we will present to you later this afternoon. What did I miss, Kathy? Would you like to go right into your presentation, or should we answer questions now? What do you think would be?
Just wanted to add just one little other detail too, because we are not, we have not closed FY25 yet. Typically there are some minor adjustments that like journals. We had to enter adjustment journals all the way till last Friday, August 22. So it's very minor compared to your allocations. It's very close with the numbers and then spent. So little adjustments do take place for payroll assessed fringe benefits, journals like things, so it does happen.
So that, but we shouldn't expect that FY25 unspent number to change that much then.
Correct.
So
It
it's
will
not
change.
like, it will change, but
It
it's
will
not like
change.
you're gonna get 700, and you don't have 750,000 in
No.
accounts payable and racial equity, correct?
No.
Okay.
So for instance, especially we just transitioned to a new financial system as of 7/1. So the conversion from our old system to new system was still taking place. So those adjustments were still being accounted for, but no, not that much. It would be a very small change in that unspent balance.
I think, Director.
Yes, Director.
Just a point of clarification, in the unspent column, that could be obligated but unspent. So it doesn't mean it's all unobligated. There could be a mix of both.
It can be encumbered as well, in contract.
That's what I meant.
Yes, and Kathy will present that data in a moment.
Okay.
That's a great clarification, Director. That is correct, right, Kathy? So we will show you how much is encumbered versus not in a moment. The other point that I wanted to add as well is that you will see, and we'll get to the appendix later, but the specific initiatives can be spread out over multiple years, but they're encumbered in one specific year. So, the 20.7 million is allocated and encumbered in this fiscal year. That doesn't mean that all of the money has to be spent in this fiscal year. And that's something I would argue unique about the settlements. Lots of federal grants require you to spend every single year. This pot of money allows you to spread the spending over multiple year contracts, but all of that is encumbered in one year. And that was a point of confusion, I think, at our last meeting, which we just wanted to take the opportunity to clarify. Other questions before I turn it over to Kathy? And Anna, Kathy, anything else to add to this slide? Okay.
Great job.
Kathy, over to you. How does this fit into the big picture?
Yes, thank you for saying that. That's a perfect way to get into this. So it's pretty clear. It's this slide and, word for word, it's really telling you, this is the big picture of 2023 Medicaid substance use overview. And I just this was also sent out to you all by email, the survey. It's also printed for you all, so you should have a copy as well. This was the 2023 survey that was conducted by the Office of Management and Budget, OMB. And this, I spoke to OMB before we put these slides together. This is a public document, but I talked to them about how much do you think that this has changed to date? And they said that it's pretty close, especially when you're thinking about percentages. So I wanted to go over this with you all because you had asked in the last meeting about what it looks like for federal funding. When it comes to Medicaid, when it comes to federal, grants, there's a lot of money out there. So let's start off with the state spent more than $245 million on substance use programs and treatment services. Medicaid claims accounted for 70%. So that helps us to all think about the big picture of this while we're thinking about settlement funds, and you all have the information that you need to get to the conversation around 2027. Treatment services were $160 million. Prescription medications was 11 million. These claims served more than 20,000 unique individuals, including inpatient and outpatient treatment, rehabilitation services, residential treatment, detoxification, psychiatric services, and prescription medications through pharmaceutical claims accounted for 6,500 individuals with an SUD diagnosis also received. So the source is actually at the bottom, and again, you have this, but if those of you who are also listening online, if you wanted to click on that link, you should be able to, or you can put in that in your browser, and you should be able to look at that survey. The next page is substance use disorder non-Medicaid programs. As you can see here, opioid settlement and stewardship funds represented 15% of the total SUD programmatic funding, while federal funding accounted for 68%. 77 million in additional resources not covered by Medicaid are administered by the state. EOHHS, DHCDH, and RIDO are collectively responsible for approximately 70% of the total non-Medicaid SUD funding activity in Rhode Island. So this is just a really interesting pie chart to look at so that you can kind of see all of the non-Medicaid funded and kind of what the percentages are across the state. And so with that, I'm going to talk less, and I'm gonna hand it back over to Brandon if there's anything else you wanted to add to that part of it, and see if anybody has any quick questions, and then we can go into the overview of programmatic investments.
Yes, Dr. McAdoo.
Quickly, can you just clarify like an example or two of non-Medicaid programs that are sponsored by them?
Do you have some examples?
Well, we're
Medicaid,
actually gonna
yeah.
go over some of the federal funding. So this could be something, for instance, we have our director for BHTH. This could be something, for instance, that is funded by SAMHSA. This could be something that's funded by CDC, Director Larkin. So those type of things, yeah.
And the other
Rhode Island.
agencies that would receive federal funding would be the Department of Corrections, DCYF.
Yeah.
So they are in there, but the bulk of the non-Medicaid federal funding goes to those three agencies that you see listed on the slide, but not exclusively.
Exactly. And the survey, as you have, if you want to take a look at it, it's pages 4 and 5. It really gives you more detail. I just wanted to pull out the high level stuff and not get into the weeds too much. But I wanted to show the big picture of, that was asked. And it's important to think about of how the funding, federal Medicaid and also federal funds and our overall landscape of funding around SUD.
Yes, Director.
So I'm putting these numbers together correctly. 68% of the federal, so the total expenditure is 245 million. 68% of that is federal, 15% is stewardship, which leaves you with like 17% that's coming from either grants and or general revenue. How much is general revenue? Do you know?
11%.
11%?
Right, so that's.
It's in the
It
slide.
is in that slide. Oh, yeah, okay, got it.
And I think it's more detailed in the survey as well.
All right, so those numbers, and then restricted receipts is 4%, other funds 2%. You did your math right.
Okay.
I mean, that's striking.
Yeah.
Actually, that the vast majority of the funding is not from the state.
Yeah.
Yes, but if you think about it, it's the reality of most
Public health?
core public
Leave it
health
in that
is the
sentence,
same.
yes.
And there was a time when public health was even higher, in fact, than this 60% or 70%. The state, Rhode Island, with all due respect to the legislators here, but most of the
Budget
time.
starts with the governor and then. That's the last act, I have no problem saying that out loud.
When you compare Rhode Island with the
But you
other.
are, be careful to wrap
With the other
say that.
states, when we compare Rhode Island to other states from a public health, from a behavioral health, we have a tendency not to invest in programs from a general revenue. We are, from the New England states, the one with the least investment from general revenue into core public health programs, into behavioral health programs. We invest in the core mandates, the nursing homes, the food inspections, and so forth from a public health perspective. I'm not talking about the rest of the budget. But it's a known fact that the state relies heavily in federal funding. And I think for us all as a committee, it's going to be important to keep that in mind because of the fact that at the federal level, we have major changes coming our way.
Yeah, nobody ever told me that before I took the job. Thank you. I have learned it.
Keep saying that because it's the reality.
And the other rationale for presenting this to you all today is that, the settlement is actually a relatively small proportion of all of the funding. So we really want to think about how to best complement the federal sources of revenue that we do receive and extend its effectiveness and value, right? So that's how we're thinking about it. And I encourage you all to do the same, is think about how the settlement dollars take us farther than these federal funds or fund other programs that federal resources do not support. Yes?
Yeah, so it's fair to say that some of these proposed allocations are with the intent of leveraging other federal sources,
That's
right?
Yes. That's right.
Probably be here for the next month if we really get into each one. Okay.
That's right.
And I think it was an ask that this committee had made to be very transparent about how does the settlement funds compare to the rest of the state. Many times we had the question that was posed here, like, why don't we invest so little? It was how it was posed to us in the past in treatment. And I think one of the reasons is here. I mean, when you think about Medicaid claims investment, that is mostly treatment. And so when you have that level of investment in treatment, we do less with these funds that is less, and we can invest in these other things that either general revenue or federal funds are not investing as much as, for example, prevention or harm reduction. So that's why I think having this big picture is important, so we see how we leverage where we are currently investing and where we're not investing. So we do it not in vacuum, but within that context.
And most of that federal money is in Medicaid, and that's
Medicaid separate, and then you have the federal grants that you saw that number.
But most Medicaid money is actually federal money. And most of the federal money.
Most Medicaid money is a mixed. In fact, you have Medicaid, it's a partnership.
Right, but I think, well.
Federal and state, general revenue.
But most is federal.
Oh, yeah, about to change. It depends, you have it, if you do it 50-50, most of the things administratively, some would be 75-25, depending on the level of service and all of those things. But it's usually a good way to do it, kind of 40-60 for Rhode Island.
Understood, but and I guess the point I'm making is that that's a significant vulnerability over the next 3 years.
Oh, it's a huge vulnerability over the next 3 years.
That's where most of our vulnerability actually is as a state.
Right.
So in fact, we have a meeting coming September 9th, since we're talking about that, where we're going to be discussing the Medicaid federal proposed changes. It's a public meeting. In fact, I know you all received that information, so I invite you to log in or attend in person. But we're going to be having that discussion on September 9th to at least understand what are the changes that are being proposed that impact the Medicaid program. Legislators passed, thank God, a very good requirement to EOHHS to do this private-public approach to study and make recommendations. We have a report that is due on the 31st. We are doing it looking at SNAP. We already did the SNAP one. There's a survey going on right now, so I encourage everyone to respond, to look at it. Then we're going to do Medicaid on September 9th. The following, we're going to do health source RI because of the expansion population impacts. And the report will be due.
Okay. Let's, what I'd like to do now is move us along to Kathy's next part of the presentation. She's going to walk you through a mapping of how the settlement-funded initiatives align with the other revenue sources, federal funding, and the stewardship. This slide has the summary of that. What we have done is put very detailed information in the appendix which Kathy can refer to and we can refer to later in our discussion. The appendix actually has every single funded initiative broken down by the funding source, the contract timelines, and the partners who are receiving the funds. So that is all there in your information packet, and those slides will be publicly available as well online after the meeting. We felt like it was too much to actually walk you through those, so Kathy's will present the summary, and then we can certainly go and dive in to specific pillars if you would like to. So with that, I'll turn it back to Kathy.
Thank you. So as you can see here, we've broken this out by pillars. This is basically giving you that overview based on each pillar. There are 8 pillars, as you all know. There are 4 corporate pillars that have been in existence since 2015, 2014, I think it actually started. And then we have our cross-cutting pillars, which are racial equity, the administration, emerging issues, municipality, and data all fit into one bucket. And then also our social determinants of health. So as you can see here, I'm gonna really just go over the totals, and then I'm going to give you all time to kind of digest this, because if I go line to line on each of these, it's gonna be really boring and you're not gonna wanna hear me do all that. But you have it in front of you, so you can take a look at it. And as Brandon said, if you have any questions, you can always go into the appendix and take a look. But I think that for this body, it's really, we wanted to give you that big picture. We started with the other 2 slides, but we wanted to give you the big picture of how much is actually happening in the state. I also want to note too, that we actually put this together, and I want to thank my colleagues at BHDDH and the Department of Health, and also folks at AOHHS, because we actually put together all of this information in a 3-week span, and it was a pretty heavy lift. And as you can see in the appendix, it's a lot of information. So many of these may be estimates, so I just want to kind of note that to you all, because we put it together very quickly, because we wanted to get you the information. So the totals for this, and you can go to the next slide, because I have a summary of it, and it's really easy to digest this.
That's such a quick question, because I really like this slide, and I appreciate the work that went into it after our last meeting, and kind of rather providing context over each of these terms. Just from my own head, we talked about contracts and multi-year contracts earlier. That totaled encumbered amount, does that include any contracted dollars?
Yes, it's all contracted.
Okay.
That's what encumbered.
So, all right, so it's fair to say there are no contracted dollars that are not included in that encumbered dollar?
Exactly. Well, it is encumbered or obligated. So if there are some that are in, say, an RFP, is a request for a proposal, and that money needs to actually be available for the applications that come in, it's not technically in contract yet, but it's obligated, and that was accounted for in detail.
In the encumbered amount too?
Yes.
Okay, all right, perfect. I think that's what I was kind of fixated on last meeting, so I just want to say, like, thank you for giving us the understanding that, like, okay, so, you know, let's just use that first pillar, because it's right there. The total encumbered settlement number is 400,000 for racial equity, right?
Yep.
Per last year's recommendation, there was a budget of 1.15 million, right?
Mm-hmm.
So that means that 700,000 is still not encumbered of that money that's been budgeted.
It's in planning.
Yeah, but it's not, it hasn't
not,
been
and I wanted to
contracted, it hasn't been,
encumbered
so.
or obligated.
What?
Encumbered or obligated.
Okay, so it may be in planning, but it's not like, okay.
Yeah, there's no RPO.
Because I think a key aspect, and I'm sorry, I know we're going to the next slide, of this is capacity in the state of Rhode Island. And, you know, we're gonna go through each one of these, but I think a real look has to be given at what do we actually have the capacity to do? And is that an indicator as to maybe why some of, in these categories, a high percentage of the dollars have not been encumbered? That's all. Because, I mean, right now I'm looking at a slide that says around a third of the money that was encumbered for that first pillar, only a third, I'll say, has been encumbered. So, you know, we have work there to do to encumber more of that money, I guess, before we maybe start. I think it's a leading indicator is all I'm gonna say.
Do you agree, Kathy?
Yes, and I think I think too what Brandon said earlier about that is where the rationale behind a lot of the recommendations when we get to that part of this for FY '27. That was one of the rationales.
So, but thank you, Kathy, because I know that was something we kind of drilled down on last meeting, so thank you.
Just to clarify, what time frame are we looking at?
Yes.
That was a great question.
That's my
Brandon
question.
asked the same question. So if you go back, you would, I can't say the exact, because this is going by contracts or estimated timeframes. So if you go back, it will give you specifically by initiative in the appendix. So we are looking, we asked for 23 to 26, but there are some contracts that are multiple year contracts. So you'll see some that may be in contract with 27, they may be through 28, because there was enough money to the point of there was additional dollars that were in that pillar, or in that initiative, I should say, and we planned projections year over year.
Okay, so it's since the beginning of time.
23 mostly.
Okay.
There's some that were a little bit before, especially from.
Okay, so it's not just like one fiscal year or a fiscal year and another future fiscal, it's since the beginning of the spend and the allocation. Okay.
For the settlement, it is since the beginning of the settlement,
Yes,
right?
from
So
the
that
beginning.
first column is since the beginning of the settlement, yeah, and then the other columns are 2023
Okay,
mostly.
thank you.
Do you want to go to the summary slide, Kathy? And yeah.
Okay, so I wanted to just give you a summary of what we, what you were just looking at in the table, as well as what you can see again in more detail in the appendix, is of the $69 million in settlement funds, which is from 23 to 26. That were allocated, more than $61 million has been encumbered in contract or obligated to pay. So that, I hope, gives you a better idea of kind of what it looks like as far as getting this information. Getting the information out to you in the most digestible way, because again, it's a lot of details. Harm reduction and rescue pillars and priorities have the greatest amount of settlement money funds encumbered or obligated, and the least amount of federal funds. Recovery, treatment, and prevention pillars and activities have greater amounts of federal funding encumbered. So those are some of the 3 points that I wanted to kind of say to you all, so that as you dig into this or you think about this, these are some of the key findings. And I think we also have another summary that I think Brandon is going to take on for the next slide.
Yeah, and then we can answer more questions.
Yeah.
So as I was able to digest this information before the meeting, I wanted to put together my own summary. So these are really just my own key take-home points that I wanted to share with the committee this afternoon. The first is what you saw in the pie charts, right? That the settlement really represents a relatively small, but I would argue absolutely critical component of the state's response to the overdose crisis, because there are less restrictions on how we use these funds, and they can be spread out over multiple years, among other reasons. The vast majority of the funds go to community-based partners and organizations, and those are all listed in the appendix. So you can actually see every single funded partner in the appendix. We prepared that for you. There are more than 100 contracts in total. The vast majority of those funds, though, are going out to community organizations. Very little is ultimately held by the state. And as I highlighted actually earlier, one piece that we wanted to clarify from the last meeting is that in any given year, you recommend the allocations. There's RFP processes, vendors can apply, and then ultimately those contracts can be spread out over multiple years, but they use funding that was allocated by you in a specific fiscal year. And all of the specific dates are in the appendix as well, so you can see how that is spread out. And that was one piece of confusion that we wanted to apologize for from the last meeting. Obviously, no money has been allocated in fiscal year 2027. You have yet to vote on it. So that is all on the table, essentially that 10 million that we'll be voting on today. And finally, as Kathy will show a bit later in the meeting, and as included in is included in the appendix, one way to think about the settlements are a combination of supporting infrastructure to support the state's overdose crisis. Data is a good example of infrastructure evaluation. Pilot projects that are being funded, things like the Overdose Prevention Center. One-time infusions, those are things like expanding access to residential treatment facilities, and then sustaining programs as well, which is similar to infrastructure. So the other thing that we have done, Kathy has done, is break down all of the current initiatives by that category. And as you'll see in fiscal year 2027, because there is less funding available, we are recommending more of the funding generally go to sustaining the infrastructure and supporting fewer pilot programs and sort of one-time infusions. So we'll get to that part of the meeting a little bit later. So those are our big picture summaries. The next step is to do another public comment. We have a few minutes for questions actually, and then we'll get into the real discussion, which is the recommendations for fiscal year 2027. Any other questions from the committee so far?
Sorry.
Yeah, Senator, no, love it, yeah.
And I appreciate what you said about we haven't allocated any of the, to the funds for FY27.
Yeah.
But there are funding expectations because of the encumbered funds, correct? Like, so if I look at harm reduction, there's 15.1 million total encumbered for settlement funds, right? And then if I go back to the very beginning, to date, the budget that we've approved as of last year was only 9.1 million. So theoretically, I mean, we have to operate within the confines of contracts and encumbered funds too, correct?
Yeah, so the encumbered includes all the way from 2023.
Mm-hmm.
So
Okay.
in looking at the budget that you're looking.
I'm just comparing the slide on 28, on slide 28, harm reduction, 15.1 million total encumbered settlement funds, right?
Yeah.
To the number on slide 25, harm reduction and rescue.
Yeah.
So hopefully it's apples, who knows if it's apples to apples, but you have 9.1 million for the budget that was there. That is the number that this body approved last year, right? I would imagine, or there. Yeah, that's the carryover plus whatever.
So some of this includes spent. So some of the encumbered has already been spent. So I think that's.
Okay.
So, and we only are showing you spent. This is the spent all the way through, but it's not this page that you're talking about for the budgets. It's the spent is included in that encumbered, if that makes any sense. So the budget that you're seeing is minus whatever was spent, because this is showing you unspent, not spent.
I think Senator, this may or may not be what you're asking. But I think what you're asking is let's just use 10 million that we have to now allocate.
Mm-hmm.
None of that money is baked into the funds already encumbered, because they can not encumber funds that have not been allocated.
That's right.
So the $10 million is not money that has been spoken for.
Exactly.
It's in addition to the
It's in addition to, okay.
It's the new money that you're gonna add to the encumbered dollar amount.
Does, yeah.
Okay.
Yeah.
So in other words, the 2.75 that we're going to be asked to vote on for harm reduction and rescue, if we were to zero that out, let's just say we zeroed that out, all those contracts could proceed. Like the encumbered funds and all that could proceed.
Yes.
Okay.
All of the
All right.
current income existing
money's there.
contracts have money in them.
Into out years.
The only situation you could have, let's suppose you had a contract, a project, not a contract, that you have a project that is a 3-year project. And we have entered in the first year of that contract because that's the money that we have allocated for that project. That's the money so far. And we are relying on this year's allocation.
That's exactly my question, Mark.
Continue.
That's exactly my question.
So that's what I'm
If we're
asking.
entering, is year 3 of a 3-year contract?
Not necessarily.
Okay.
It depends on how those contracts were constructed, and that differs from agency to agency, but the year allocation in a contract is for the money that you have encumbered. So if it's a 3-year contract and we encumbered the whole dollar amount, they are good. It's like a grant. If it's a 3-year contract, but we were doing a year-to-year allocation, and that's what's allocated in the budget, if you eliminate next year's allocation, they would not have that second year. But their contract, existing budget allocated is done, it's protected, that will not be touched.
And that's the work that gets done at the agency level in
Yes,
terms
yes,
of
yes.
continuing a given program. If it is going to not continue, if there's not additional allocation versus a program that may have been fully funded for 20 years. I mean, not 20 years, but there is money that's encumbered that may have completely funded that given effort through the end of the settlement. But I think that's probably the exception. I have that right? Looking to you. I have that right, correct?
You can pull up an example too in the appendix, might be helpful at some point to give a sense. Just wanting, we can do that.
Yeah, and I think that one of the things is these are great questions, and I'm glad that you're all asking them and that you're understanding. But all of this, as Director Larkin said, this happens on a programmatic level across the agencies. That is what we all do, and we meet on a monthly basis, as I said last month, and we talk and we look at each of those programs. And as we move forward in this, you're going to see where we've worked with the agencies, and thank you for giving me credit, but I have to credit the programs across the agencies for actually giving us the information so that we could actually kind of put a category or a status of infrastructure, sustainment, pilot, so that you could get a sense of where we came up with the rationale on some of the percentages for the $10 million.
What I'd like to do maybe is let's go to one example and then we'll do public comment. Can we do still slide 55? I'm just picking one randomly. We didn't want to go through all of these pillars line by line, but for me, this was helpful to get a sense of what this looks like in practice. Great, okay, so this is the recovery pillar. So this gives you an idea of actually half of the initiatives that are supporting the recovery pillar. It shows you the agency that's responsible for awarding those funds, who is receiving those funds, those are the partners, and then the source of those funds. So you recommend and allocate this, the settlement. So that is that line. And then I mentioned the stewardship funding is not controlled by this body, but is also a source of revenue through a tax on opioid prescriptions, and then other federal sources. And then the timelines, right? So that's what the Assistant Secretary is getting at, is that the timelines for each contract do actually vary, but all of that funding has been encumbered from the beginning, especially for the settlement column, from the beginning of the settlement to this current fiscal year, correct? So, for example, Building Futures was a large contract to support recovery capital for industry workers, but it was spread, as you can see, over many years. So that's been encumbered through 2028, basically.
With the existing budgets,
With the
not
existing
anything
budgets.
we don't have. We wouldn't put
Yeah.
something in contract if we don't have the money on hand.
Yeah, because that is what's unique and some powerful about the settlements is that you don't need to spend them all in 1 year. So it allows that opportunity. Yeah. And the other point here, I like this example because you can see as well how the state has sometimes braided funding. So one program like Recovery Friendly Workplaces is funded actually across 3 sources. So that hopefully this is helpful to really dive into the weeds and you can see all of the settlement funded programs and how they're either supported or not by other federal and stewardship sources. Okay. Any other questions? I wanted to leave about a half an hour for more discussion on the recommendations, so we're doing well. If there's no other questions from the committee, let's go to our second public comment of the day, and then we'll get into the last agenda item. All right, so let's start with members of the public in person. Yeah, Colleen, nice to see you.
Hi, everybody.
The floor is yours.
I'm Colleen Daly, I'm the Executive Director of Project Renew. I just wanted to respond to your comment and then sort of to back up what Kathy was saying. I was looking at some of the dollars that are sort of designated for harm reduction and put forth for the Overdose Prevention Center, and realizing that we have our treatment provider, Victa, who is utilizing those dollars to provide treatment on site for the folks that we serve. So we've got a full-time nurse, we have a full-time behavioral health clinician, and then we have a part-time prescriber. So, you know, obviously doctors, nurses, they're very expensive. So this is a huge cost for us, but it is coming out of the OPC budget, which is coming from the harm reduction pillar. So just, I know that there's cross-cutting, so there's sort of racial equity baked into all sort of different pieces. So is the harm reduction dollars. People are accessing 33,000 recovery housing beds each year through, you know, accessing our services. So there's a huge connection to treatment, to recovery throughout everything that we do, even though it's sort of coming from the harm reduction pillar. So I just want to explain that in terms of when you're doing your allocations.
That's really helpful.
Very helpful. Other public comment? Yes.
I thought the public comment was at the end.
Based on feedback, we've had 2 public comments and we do them earlier in the meeting to avoid having folks stay to the very end.
Oh, okay. I mean, in the past, it wasn't, yeah. Okay, I want to talk about the message that I saw last year about these. Do you mind if I stand up?
Sure, and as a reminder, try to keep your comments to under 2 or 3 minutes.
Okay, well, I'm speaking to these 2 gentlemen also, so that's 6 minutes.
Sir, no, we need to have enough time to discuss.
Yeah, it really is we really
Yeah,
have a
you
lot to
can't,
get
you
through.
can't
2 minutes.
cede time to somebody else. That would be out of order.
To people is wrong. This is at movie theaters, learn about safer drug use. This is on a bus stop, learn about safer drug use. This was the packages sent out last year. I hope they're not going out from URI. This was all over West Warwick. It pretty safer drug use supplies like naloxone and fentanyl. Based on the data from DEA on these fake pills, 2 milligrams of fentanyl is considered a potential fatal dose. Pills tested in DEA laboratory average 2.4 milligrams of fentanyl, but have ranged from 0.2 milligrams to as high as 9 milligrams. So I just don't see where using drugs with Narcan or without Narcan or with harm reduction or without harm reduction is safe, okay, based on, I called it State House and I called it Russian roulette. So I hope the message going forward in this new budget or proposed budget, you find a better way to sell your harm reduction. And I am 100% for harm reduction in needles. I've seen a lot of people die from cured needles. But the message we need to get out to Rhode Island citizens, Massachusetts citizens, Connecticut citizens, whatever, is there is no safe drug use. Anytime you buy something off the street, you're potentially you're taking your life in your own hands. And that word safe is really needs to be eliminated from your budget based on the data from the DEA. So, do you have any questions?
Thank you.
It's been 2 minutes, sir. Thank you. You're welcome to look at the materials at the back as well.
Everybody knows I lost my son in February of 2024. Dead in my pocket. So, any questions on this data from DEA about the fentanyl in these pills? Okay. So,
thank you.
Thank you. You know, that message, safer drug use is wrong. Okay, maybe it should see how to prevent opioid use or something to that effect. But again, once people see that, once a young somebody with a past history of substance abuse sees that word safe.
Thank you for your comment.
We have to do it to
Thank you. Any other public comments? Great. Okay, thank you all. So we'll move now to the meat of the agenda, which are the recommendations for fiscal year 2027. So I'm going to walk us through very briefly the process for arriving at the recommendations that we're presenting to you based on feedback at the last meeting where we really heard you and say, like, give us more information on how you arrived at these percentages. So I'll walk you through some high-level stuff. Kathy will fill in a little bit more information, and then we'll have a rich discussion on the proposed recommendations and vote. In terms of process, we do really have to vote today because the vote does have to go to the secretary, who either approves, modifies, or can reject the recommendations. If they are recommended and approved, they go forward along into the state budgeting process, which takes some time. He may ask us to modify or reject the proposal, and then we have to come back as a board as well. So we need time to build that in. The outcome of the vote today will be written into a memo by the staff, reviewed and signed by me, which will then go to the secretary after today's meeting. So that's the process. If you go to slide 33, So I always like to just remind us, the big picture here driving the recommendations are the principles, the Johns Hopkins principles for opioid settlement spending. We've seen this many times before, so I'm not going to go through these again. But the state and we all keep this in mind as we are making our decision making. The first 5 come from Johns Hopkins, and the last we added, which focused on considering sustainability. Next slide. So then the other important piece, critical piece that's guiding the recommendations we have for you for your discussion and input today is feedback from the task force, from community members, and through public comment. I'll remind you that 150 people responded to the task force survey asking them to rank their priorities. That was analyzed, synthesized, reported out to you by Kathy in May, and then has gone in and been integrated into the recommendation process. And we are now in August, where we have to vote on fiscal year 2027 recommendations. Next slide, So. Okay. A couple other points that we've already covered to some degree, so I'm going to go through this quickly. We also consider the continuum of care framework, right? I think Chris highlighted this earlier very nicely, that we invest monies across the continuum of care. The way I like to think about this is we want to reduce the rate at which people become at risk for overdose. We want to lower overdose risk in people who are actively using, and we want to increase the rate at which people enter into recovery as well. And so by investing across the continuum, we're doing all 3 of those things. That's the framework there. As was already discussed earlier in the meeting, these recommendations also look at the amount of unspent carry forward across pillar and inform some of the changes you'll see in the subsequent slide. As I mentioned earlier as well, because there is less money in fiscal year 2027 to work with, the focus generally will be on sustaining programs that are working and meeting their deliverables, maintaining the state's infrastructure to address the overdose crisis, and relatively few funding is set aside for new pilot programs or one-time infusions. And then finally, a member actually brought this up, I want to say in June, and I really liked the point, so I wanted to reiterate it, that a dramatic shift in the allocations would be very disruptive to the current programs that are funded and the current state's response. So where possible, we have tried to avoid dramatic changes in allocations. Okay, so those are my points. Kathy, over to you. You're going to walk us through the one last piece of federal information and then the recommendations.
Okay, again, hi, everybody. You can move to the next slide. Thank you. So I went across the state agencies and asked PHGDH, also my colleagues at AOHHS, just to give us a little bit more information about some of the other funding sources related to health and behavioral health. And so BHDDH is $40.2 million per year in federal funds for mental health, substance use treatment, prevention, recovery, homeless, outreach, emergency crisis work and diversion, and youth and transition. RIDO, approximately $10 million over the next 3 years for overdose data to action. That's a CDC funded program. OD2A primarily funds the harm reduction and surveillance programming and was decreased from previous CDC funding cycles. The prescription monitoring program, I want to say prescription drug monitoring program, sorry, has received a no-cost extension until 9/30/2026, and no new funding announcements have been released by the Bureau of Justice, BJA. And then EOHHS, 111.7 million of all funds, 34.2 million of general revenue for certified community behavioral health clinics, BHCs, in FY25. This is federally defined service delivery model that provides a comprehensive range of coordinated mental health and substance use services. So I just wanted to give you just a little bit more information of some of the other programs that we have in the state.
Okay, let's go to the recommendations. Oh, there they are. Thanks.
Okay. So I'm going to go, as I did last year, I'm going to kind of go over the recommendations and I'm going to hand it back over to Brandon. Okay, so I'm just going over these so that you can all see these. We broke it out in two different ways. We broke it out one by percentage, which is what you typically vote on. But we also gave you the dollar amount for that. I want to also just, let you know that, when we're going through this, we, in the last column is what I really want to bring your attention to what we talked about a little bit here is we went through and we looked at, when I looked at the encumbered and also worked with the agencies, we kind of put an idea of what is kind of happening in those pillars. The first one for racial equity, we are looking at this and most of the programs right now that are encumbered or funded in FY26 are pilot. So that's what we're kind of categorizing that as. Emerging issues and municipal funds. This was sustainment and also pilot. The reason why is because they're kind of combined. So sustainment is for the emerging issues because this is kind of like I don't know what the right word would be, but it's a bucket of money that this committee decided they wanted to kind of set aside for drug supply changes and stuff like that could happen, so that we have a small amount of money that's a little flexible. But we also have a delegated authority at EOHHS right now for the municipal funds. We're calling it the municipal incentives funding. And the reason we're doing that is because we really we've heard from you, we've heard from the community, and we hear often, how can we work with the municipalities? So this is an opportunity to fund some of those programs, some of those municipalities, and gain some data, align that with what we're doing here in the state, as well as expand some of those services. And I'm sorry, I'll give an example because it's public knowledge. We are actually partnering with the City of Providence right now, and we are working together to collect data because there's a lot of work happening with the opioid settlement funds there, and we've also enhanced some of the services that they're funding through their settlement funds. Administration, this is monitoring the investments and financing and contract management. It's really all of the things that are happening behind the scenes. This is across all the agencies. We are also supporting some BHTDH and RIDO as well with some of that kind of support so that we can really try to monitor, the contracts and finance and stuff like that. Evaluation, you've heard from Brian. You've heard, if you all didn't know, we probably should have announced this at the beginning. Our friend and colleague, Tamara, has moved on to a new position. She is actually seeking out and going to work in the school departments. That is who she is at the very core of her, but we will be backfilling that position as well to help us do our interagency work. Social determinants of health, we know that there are different things in that bucket, which is, some basic needs. We also have some homelessness initiatives and so on and so forth. That is really thinking about the infrastructure of the things that we're already funding and also some of the pilots. Prevention, sustainment, and pilot in there. We have, and again, a lot of this details in the appendix, but this is, the student assistance counselors. We also have some community-based pilots that are happening right now that Brian spoke to a little bit that we're funding through Rhode Island Foundation. Harm reduction and rescue. This is really, a lot of this is actually infrastructure because this includes our naloxone distribution center, which is where all the naloxone is distributed across the state. This is portion of this is some of the work for delivery of needle exchange, delivery of harm reduction tools. It also funds our outreach teams, which are the distributors of the naloxone, and it also goes across to our outpatient treatment centers, some of our primary care organizations, many. There are many community-based organizations that are also distributing naloxone as well, and other types of services or other types of harm reduction tools and services. Treatment, this is infrastructure. A lot of these, if you look into the details, a lot of this was one-time infusions of maybe brick and mortar, but there were also pieces of treatment that are really important to continue to maintain, such as making sure that people who are underinsured or uninsured still have access to treatment on demand. So there are actually contracts that are through the outpatient treatment centers and also residential treatment centers that are part of this pillar as well. I'm only giving you some examples, there's a lot more, trust me. And then recovery, increasing recovery capital, because we want to make sure that we are funding and we're looking at things in a holistic view, and that we're making sure that people can go through the continuum and they can also maintain their treatment, they can maintain their recovery. And you saw some examples of that as well. And that is infrastructure sustainment and pilot. So on the next slide, it's actually broken down by dollar amount. And again, these are sort of estimates based on $10 million. And then we wanted to give you a whole number for the percentages. So it's not anything different. It's just literally the amounts of money that are in here. You know, I have a note from the last time I did this, so I'm going to leave that alone. But I wanted to just kind of show you, and this is a line that I really wanted you to mostly focus on that status line so that you can kind of see that's how we kind of broke this down. And this was based on the exercise that we did with the information that we got from our agencies. So if there's any questions about anything else, I'm more than happy to answer that. But I think still, if we can go back to the percentage slide, unless there's another slide for you, Brandon.
Nope, that's it. That's where we
I
want
can
to
hand it back
have
to
the
you.
discussion. Yeah. The last piece I'll say before we open it up for discussion is that this is 10 million currently in the bank, so to speak. As a reminder, the Purdue settlement is coming in, and that will be additional funds that will be made available. The specific payment structure has not yet been made public, correct, Michelle? So our hope is that our plan would be to discuss that at the next meeting, which would be in October. So we are asking you to vote today on the monies that are currently allocated and available in 2027, that 10 million. They'll actually be quite a bit larger once the Purdue settlement is finalized. Did I mischaracterize anything, Michelle?
Just one quick point, I
Yeah.
just wanted to point out, so I know not officially in the bank, but this is a payment schedule that we have, that the funds will be coming in based on what's already contracted with the settlement. So not officially in the bank yet, it comes in the year 27, but it's there. I
Like
just wanted to
this,
say it,
yes,
But
okay.
it's on the schedule.
It's on schedule. This is scheduled, the Purdue settlement is not yet
It's
scheduled.
not yet, correct.
Thank you, yeah, thank you for that clarification.
No problem.
Okay, so that was the thought, is that we ask you to vote on the 10 million today, and then we return to how to think about what is the process for allocating the Purdue settlement in October, assuming that payment schedule is available by then. Okay, so would love the committee's feedback on what we provided for you, how this is looking. We'll be asking you to vote on those percentages that are bolded in the fiscal year 2027 line.
Do you need a motion and a second first?
Yes, we'll get there. We wanted to spend at least 20 minutes just to discuss, hear your
I thought
feedback.
actually, I think you technically have to have a motion and a second before you can.
Oh, okay, thank you, thank you. I'm still learning. Thank you, Director.
I move that we accept the recommendation.
Okay. Second? All in favor?
Discussion.
No, no,
Discussion.
no.
Now the discussion.
Okay. Discussion starts now.
12 painful years on the school committee.
Yes, Director.
I'm trying to understand the ground rules up front. So the intent was not to start new pilots in 27. But was it to sustain pilots already funded and working from 26, to 25 and 26? So I noticed, and this is clearly not the forum be negotiating individual stuff, but the respite, under the social determinants of health, there's a medical respite program that's listed as pilot that is a couple of $1 million. So would that be sustained by the allocation that for 27, given that that's only $500,000 being put in? I know there's additional unspent money. So I'm just trying to understand if some programs like that are necessary don't end up getting funded because we haven't allocated enough money in 27. That's the whole thing.
Yeah.
I mean, I would answer this way, is that I'll be meeting with the agencies and also internally about that. So as far as making the programmatic decisions on that, to your point, there is still unspent money in that bucket for FY, all the way from FY '23. So of the FY '27, the vote today, and I'm going to go more broad than just medical respite, broadly speaking, if it is a pilot and it can't be sustained, because we're not looking at settlement money as we're going to sustain forever and ever and ever, unless it's infrastructure and there's no other funding sources. So to kind of answer your question is, it's hard to answer that unless I talk to the program level and across the agencies of that, but there is money that has not been spent in that bucket.
Director Larkin?
And I guess to the director's point, that's always going to be a risk for all of the programs that we're currently engaged in part because of the instability of the federal funding structure, which you know just as well, if not better than I do. So if I could gloss this, it seems to be what we're doing here, if we accept this recommendation, is the big deltas are in harm reduction, data, and to a lesser extent in treatment. And we are shifting our proportional funding from treatment to harm reduction and data. I actually support that. And the reason I support that is I think our greatest vulnerability in all of this work is going to be in harm reduction. Mm-hmm. And to the previous gentleman's point, it's not safe use. It's probably the one thing we would agree on is there's no such thing as safe use. It is safer use. It is harm reduction. It is overdose prevention. It is not creating an environment where you have quote unquote safe use. That is possible. That could be an aspiration, but unfortunately not in the political climate that we live in.
Yes, Adia, and then Director.
Okay, so I have some concerns about the recommendation, and I don't agree with shifting money away from treatment. And if we need to shift money away from things, I think it can come out of other buckets. I think we have significant risks on the treatment front with Medicaid coverage. And I understand that Medicaid rates themselves cannot be funded through settlement funds, but there are a lot of other ways to address shortages in services and in infrastructure that are not rates. And there's a way to infuse money into treatment that is not directly tied to rates. We have heard on numerous meetings that we are falling short on treatment on demand. There are segments of the population that have to wait for a long time for treatment, and whether it's the availability of treatment beds, which is one aspect. Residential treatment is obviously one piece of the puzzle, but there's also non-residential treatment that's very important. We've, I think, all been educated about that. So I feel very strongly that the state, to the points that the director made earlier, that Anna made earlier, if this is a priority and we want to address the opioid crisis, we have to invest in a treatment infrastructure that makes it so that individuals who need treatment, who want treatment, who are ready for treatment, can get it, and can get it when they want it and when they're ready for it. And that's where investment needs to be. And that might mean that some other things don't get money, and that's very sad because I wish everything could get money. But honestly, that's what this money is intended for, and that's where it should go to. So I don't know, I can come up with some ideas about where we plug the money from, but I feel very strongly that we need additional investment in treatment. And I know the state always has challenges in getting the money out. I know there's always challenges in building capacity, and so the money can't be spent in an instant. But that's where I think our investment needs to be sustained. So that's like my big picture takeaway. I am concerned about the amount of money that continues to go into more difficult to measure categories. I mean, there's some stuff in prevention. I know we love prevention. It's great, but I think it's difficult to measure. And I think a lot of money that goes in there can come from other buckets. I think there is money that is going towards administration and things within state government. Labs, PDMP, all these things. These are things that should be funded through general revenues. These are state expenditures for state infrastructure, for departments that should be funded by state government and should not come out of these settlement funds. So that's my 2 cents.
Yeah, I just wanted to thank you so much. I really appreciate your passion and your insights. I just wanted to clarify, based on my reading of the budget, it seems as though this proposal is not, or that these numbers is not suggesting a divestment from treatment relative to our allocation from last year. So relative to fiscal year 2026, which is already been allocated, during that year we allocated 12%, and this in 2027, the relative proportion is actually an increased allocation toward treatment. So I do want to point that out.
But the dollar amount is significantly smaller, and you're going to see that year over year because the amount of settlement funds that are available year after year goes down. So I'm looking at the dollar amounts that are actually going to go towards treatment, and that is a very small dollar amount. I mean, the percentages are great, but I'm just looking at bottom line money, and I see that it is $1.25 million out of $10 million that is going to treatment, and that's insufficient. And I don't recommend that money be backfilled from taking away from the harm reduction bucket. I think that has been critical. That's been a critical investment, should continue. It's worked well, and so I'm not recommending that. I think we need to find it in other places, but I do think we need to find money to increase the treatment bucket.
Yeah.
So just as the counterpoint, treatment still remains the single biggest allocation we make. And if we go back to the total amount of what's being expended in the state, the $240+ million, 170, I think of that, or 160 of that is actually in treatment as well. So we are supporting, I mean, I think we would all support everything we're doing here, 10 times more than what we are. And I don't disagree with you at all about this needs to be continued, that we need more state funding. I hesitate to say that. But not because I don't believe it, but because I know. But the actual delta in treatment is relatively small compared to the total amount being expended for treatment statewide, the $160 million, and actually still leaves treatment as the single biggest allocation that we make. And again, I think that our biggest vulnerability in terms of programs stopping, dead is in prevention right now, harm reduction.
Yes, we'll go to Director Clark. Yes, yeah.
It looks like the allocation for 26, all funds, is about $8 million for treatment, 7.9. Once you do the unspent from 95, the allocation for 26. What's our annual spend on treatment, average for the last few years or for last year?
From what?
From the settlement specifically?
From settlement. So if we're spending settlement money at a certain rate, I don't know if it's enough, but that's what we've been doing. Is the 7.9 sufficient to cover that for the next few years? That's one way of looking at it.
But I think you guys, I mean, we are here to listen, but so you asked me a question. I think we can respond in isolation or do what you ask us to do, which is in the context of the state investments. And so I don't think we can do it both ways. I mean, either way, either we're going to look at it comprehensively for all allocations in the context of the overall investments for the state, or we're going to look at it in isolation and look only at the settlement funds and say, this is what we want to do with the settlement funds outside of that context.
Sorry, can I ask a question that somewhat dovetails, I think, with what you were trying to say, which is, I think that that's appropriate at the outset of this. Like, these are the pillars we want to support. These are the lanes we want to try to drive down to comprehensively address this crisis. But the reality of the situation is we're now 4 or 5 budgeting years in, and the director raises a good point as it relates to treatment with what is the demonstrated capacity to get this money out the door now? Is it $8 million a year? And now through this proposal, if we go below that amount, right? I don't know, maybe it's 6 million that we're going to authorize here today when you roll the unspent into what the new percentage is. What are we doing that at an opportunity cost somewhere else in these percentage allocations where, quite frankly, some of this money hasn't reached its capacity yet with what we've authorized, right? Is that, Director, a little bit of what you're alluding to? Like, if the treatment money is getting out the door and we have the demonstrated pipelines to continue to push those resources out, well, if we take a step back in any regard to getting that money out the door at the cost of theoretically allocating it to something else where, I mean, there are at least several examples where the encumbered amount doesn't come close to what we've previously authorized. So there just clearly isn't the capacity to get that money out, or I don't want to say need, there's need everywhere in each one of these buckets, but there's not the framework 3, 4, 5 years in to get it out that I can, and feel free to push back, Kathy. I think it's a good point that, you know, what are we doing, what are we cutting this at risk of?
Yeah, well, and my focus was specifically on treatment is important. Medicaid covers a lot of it, not all of it. So therefore, these funds for medication, for opioid use disorder, and for stimulant treatment are for the uninsured, underinsured, those who can pay.
Brick and mortar.
Right, and some capacity building in that. So do we have enough by this allocation to maintain that effort for next year? Because we're only allocating a certain amount of one.
Keeps it at so your question, that specific question, it keeps it level when you add the unspent funding. So you're not really decreasing capacity for treatment because of the unspent funds that has been carried over year after year. So when you look at what's encumbered to date and what's the new allocation, you would maintain, give or take dollars, whatever, you will maintain your same level of investment.
And in the process of coming up with these percentages, this wasn't done by just EOHHS. This was done in partnership with all the agencies.
Oh, yeah. I'm just trying to understand that.
No, that's not
one
understand
piece
your
of it.
question. So your question is in terms, is it the capacity diminished? No.
So, right, but the reality is last year we allocated 20 million, now we're allocating 10 million.
Exactly.
So at least in the treatment bucket, if care for the uninsured, underinsured is not harmed next fiscal year or fiscal year 27, then at least we're maintaining it. And this doesn't, I don't believe, fully incorporate any impact of some of the federal cuts that are looming and that we're all worried about.
Absolutely, and I think that's why I was mentioning the meetings and the sequence of those meetings, and I think maybe part of your consideration when Dr. Marshall was asking about what do we do with the Purdue funding, maybe that is one of the considerations that you take, that you come back with full knowledge of the impact of the Medicaid cuts, of the SNAP program cuts, because it's important for us to remember, yes, that is going to be definitely or maybe not, who knows, hopeful thinking, an impact through Medicaid. SNAP cuts are going to impact families in ways that are going to really impact their day-to-day life their capacity to even engage in treatment. And so it's important for us to keep the comprehensiveness of what we need to do. And coming back in October, after we have full knowledge of what's happening from a federal perspective, after we finish the October 31st report and we have a sense, we are all going to need to, I mean, the reality, our budgets are coming in October 1st being submitted. We're not going to be able to submit budgets, I don't think so, that are fully, without having this full picture. We're going to need to come back and understand how is it impacting and having conversations even after the submission of the budgets and be able to modify recommendations and engage with you all.
Thank you.
Let's go to Dennis, you had a question, and then I have a proposal for the
It's a
committee.
question, more so comment. I'm a harm reductionist. Looking at the monies that we're going to lose because of the current administration, which pillars are going to be impacted the most? I'm looking at stewardship dollars, other federal dollars. Which pillars will be wiped out entirely from those other possibilities? Certainly harm reduction will be. I hate to, wish we could fund everything to complete maximum dollars, but I'm looking at what's going to happen. And of course, you answer that maybe with the Purdue. We can look at which pillars are really effective and affected, and supplement that. So that's one piece. Of course, since I've been on the committee, I've also a person of color. So I've always had a concern about the racial equity piece and how we are working with those funds. As you know, you speak co-chair of the Racial Equity Working Group, and that's the least of all the funded pieces. Racial equity is equal to data, less than administration. So I have concerns about that. And I also know that through this process from the very beginning, oftentimes comments don't adjust the recommendations. I've seen that from the beginning. And I wonder at what percentage point would the adjustments be made. But I'm concerned about the racial equity piece. We know that there's been reduction, as we all know, in overall overdose, but not in Black and brown people. So should we just maintain what we're doing? Are we doing a significant job to ensure that we change those numbers? We're not investing more money into it, even though we know that it's not working. So I wonder if that's something to take into consideration in regards to the recommendations as well.
So there are some things that we know right now, although all of it is, as we've questioned about which pillar is more impacted. We know that for sure harm reduction is going to be impacted because we already received notices about the cease and desist of some activities and so forth. The same for the racial and equity allocations. I mean, on the other hand, that's from a federal perspective. And so, which is why I think it's important, if I was a voting member, which I'm not, to maintain some of these allocations that as it's recommended. To your concern about race equity, I think the position that we've explained here, and I believe folks have agreed with, is that while that was a set aside specifically for that, but the expectation very clearly is that that is not the only investment that is being made from a race equity perspective, that in every pillar, the allocations that are made for treatment, the allocations that are made for prevention, that all of those allocations we expect that the interventions are focusing on addressing whatever disparities from an equity perspective, not just race and ethnicity, but based on gender, on whatever the data indicates in every single one of them. So I personally believe and push all of my colleagues within EOHHS and across the agencies that the more we integrate and we make sure that the activities are addressing the disparities, the better off we are than trying to pull out funding specifically just for race and ethnicity. But accountability comes out in numbers.
Right, okay,
And
so
so you
looking
want
at-
to see the
looking at
change
the-
in those outcomes.
Looking at the effectiveness of the organizations, except in getting the funding, are they addressing those issues? Is a big piece, and I know that there's data out there.
We're getting data. It's not perfect.
Working on data
We're
to
working
see
on
if, when you receive those funding, are you taking into consideration, are you really working toward that end?
We try to hold folks accountable. We can always do better. And I think the accountability will be on the numbers. To the other question of the Medicaid impact, that we'll know more. My colleagues at Medicaid, in fact, at the same time we work, I was doing 2 meetings, my apologies if I seem distracted, but we were discussing the changes in Medicaid. But one of the things that we know is going to be the changes to the expansion population, for example. And so if folks who are transitioning out of the expansion population now would not have, to your point about treatment, they would be transitioning maybe in a health source RI, but if they don't transition, they will become uninsured. That would be an impact. The only thing I can say in terms of allocations is not to happen now. The Medicaid, our federal legislators were smart enough to push that in 2 years in the future. So it will impact our FY28 budget, not our FY27 budget, if that helps you in your issues about treatment and coverage.
So we have less than 10 minutes. I might ask committee members to say a touch later if you can. I wanted to put a proposal on the table to move us towards the vote. I see sort of 2 options here. We could entertain a motion to adjust these percentages based on the feedback we've heard from the committee, or we could move forward with a vote on these percentages and think about all of the topics that have come up in this rich discussion when we talk about the Purdue settlement and how best to use that additional funding. So I sort of see those as your 2 key options on the table today. Thoughts on which direction to go in 10 minutes?
I cannot stay past 3 o'clock.
Okay.
It's my motion. You would need, so just 2 points. You would need another motion to the original motion, which is still live, in order to change the percentages. Something to understand for, I think, all of us is that any given percentage change is $100,000. So you're moving from one place to another. It is sort of a zero-sum game. So, if you want to change these allocations, that's what you're doing with each percentage that we're changing. So.
I don't think we're in a position to say if we're going to increase, where do we decrease? I think it's good enough to be able to move forward to fund what we want given the discussion. And I think coming back and revisiting it, especially once we know what the federal outlook is going to be, is probably the best way we can move forward. So I would just support the motion that's on the table.
I would also err toward supporting the motion that's on the table with the idea that based on all of the rich conversation that we've had today, to then have that guide our allocations in the future with the additional funds that are in the pipeline.
Yeah.
Dennis? Where's the thumbs we have? We had thumbs.
You want, she brought them.
Yeah.
Did you really? She asked, and I said, no, we'll just do thumbs up.
Yeah, go to this end. Okay. Yeah, sorry, I forgot to.
We do have them stats. I'll give you one on the way out.
So I'm hearing, yes.
Well, Brennan, I don't know if this then if this needs to be a motion or a separate motion, like you can have two live motions or what, but I would point out that if you're looking at percentages, the percentage for administration has gone up significantly. The percentage, there is a percentage for emergent issues and municipal funds that has gone up. And this is even though we have not expended a lot of the municipal funds. As far as I know, we still do not have specific data regarding municipal expenditures of their own settlement funds, and which I believe is something that we need and should be obtained before additional monies are expended there. There are, funds in the buckets of evaluation and data that, okay, when you look at them separately, it doesn't look like a lot of money, but again, when you add all of those buckets together, there's a significant amount of money going to state programs that, again, that money, I just cannot believe the state cannot find $1 million to get a lot of this thing done, that it does not need to come from settlement funds. On the racial equity point that Dennis has made, which I think is an excellent point, the problem I've always had with this bucket is that it is a cross-cutting bucket. Racial equity should be measured in every single bucket: prevention, harm reduction, treatment, and recovery. That should be like a criteria for every program that puts in a requirement. I do not really understand it as a separate funding bucket, as separate programs. It becomes, I think, respectfully, to some degree, it's just difficult to measure. It's difficult to measure the efficacy. It becomes small dollars, and I don't know what the impact or the effect of it is. So I have always had a problem with it as its own separate bucket, and I think that it should just be a program requirement for our how many stools? 4-legged stools of the other 4 pillars. And so to me, I get it. We're not talking about a lot of money. We're not talking about a ton of dollars. But, adding $1 million or a couple $1 million to help support capacity for harm reduction and treatment, direct services, is a big deal, and makes a big difference. And I just think that that's what we need to be focused on, and that would be my recommendation, to try to shift funds towards those buckets. And to the point that the senator was making in terms of like the capacity of getting this money out and how quickly we can get it out, well, again, that's on the state, and the way to address that is not to lower our goals and expectations. It's to get better at building capacity and getting money out.
I agree. Yeah, Sean.
Just a quick question, and I wasn't here the first 2 years of it. So we seem to take the harm reduction, we went from 18 to 27%. And there's probably a reason, I guess, and then we went from treatment from 22% down to proposed 13%. What was the cause of the swing? Because I tend to agree, treatment is key. I mean, that's definitely something, I realize this isn't all the money in the world.
So one of the things is the biggest investment in the treatment bucket, and you have that in your appendix, is brick and mortar. Those are one-time infusions. And we had a presentation a couple of months ago by the state agencies, and Linda Mahoney did a really good job of really showing the different phases of it takes time because it's brick and mortar, so you're trying to find buildings, you're trying to increase beds. We have had an increase. There's also, I always like to refer you back to the documents because I can't do this alone. I actually, to BHDDH, are the folks that are doing the work. I'm only speaking to help you understand is that we have added beds to residential treatment, and we lean on our experts and our state agencies to tell us whether we're meeting what the need and what we need for like outpatient treatment. And it was presented here that we are doing really well in those areas as far as making sure that there's access to treatment in both of those areas. Like residential treatment beds have increased at different levels of the continuum and stuff like that. So that might help you understand why, because it's one-time infusions. And so that's kind of why it goes down. And again, we work with the state agencies when we come up with these allocation proposals.
Totally understand, thank you. I mean, I have 35 years in public safety, a police background, so I can tell you as far as beds go, the state is failing graciously as far as available beds.
Correct. It is.
We can talk all day long about it, we're not
That's
gonna
right.
solve it here, but thank you for the response.
So it's 3 o'clock. I do need to not hold you all hostage. So I think what we would need is a specific motion to change the allocations on the table. If not, I think we want to go to a motion to vote.
Well, here, his motion's already there,
Yeah.
the recommendation.
There's already a motion on
Yeah.
the table to
Right.
the
To accept it.
allocation, so unless it gets amended or it gets tabled, is there a harm in tabling this?
There is.
Good call.
So I'm going to call the question, and what that means is that we have to vote to immediately to either stop debate.
Okay.
If that passes, then we need to take an immediate vote.
Okay, yeah, because you have to.
So I'm calling the question.
Yeah.
Okay.
So you need to take a
The
vote.
motion to amend, I guess.
I've called the
We
question.
have a
Amend. First, we need to vote on the motion on the table, and if the
No.
motion doesn't pass, then
No,
we have the.
what I've done by
We will
calling the
amend.
question, what you need to do is take a vote immediately to end debate.
Okay.
If that passes, then you must take a vote on the motion. If that fails, then I can either withdraw the motion or you can make an amendment
Okay,
to
thank you,
my
Director
motion.
Larkin, as I learned this. So we need a vote on
Whether or not
this.
to stop discussing.
Yeah, motion to end debate and
Yes.
move immediately to approving this budget.
Yeah.
So
Or
I don't know how I imagine you'll
All
take a roll call vote, I'll vote no.
So all in favor of ending debate and moving to a vote?
Hi, good night.
I'm sorry.
1, 2, 3,
I think it passes.
7, 8, 9, 10. That motion passes. Okay, so we are moving to a
Want
vote.
abstention, you want nays
Yes, abstention
or nays?
and nays. 1, 2, 3. 3 nays. Okay, so that means we now move to a vote on these allocations for fiscal year 2027. Do I need to take a motion to that as well, Director Larkin?
You have to
Right a
proceed
vote?
immediately to a vote on my motion, which was to approve the allocation.
Okay, thank you. So all in favor of approving these recommendations, raise your hand and keep them raised, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 yays. Any abstentions? And any nays? Please raise your hand. 1, 2, 3, 4, 5 nays. All right, thank you, folks. So those results will go in the letter to the secretary. I really appreciate your time today. Thank you for staying a few minutes later. We can come back in October and continue debate on a lot of these discussions and consider all of this feedback on how to allocate the produced settlement. So thank you all for this. Appreciate your time staying over and have a great afternoon. This ends.
I know, I've done it.